Good evening, friends. It's my great pleasure to be here. Today, the topic is very specific. Levetiracetam in neonates. When I was about to come here, my friend in Bihar called me and told me that you don't come here unless I tell you give me specific answer to my specific question. The specific question was, we are using this drug in pediatrics. Can we use? Shall we use? Should we use? And how to use? That was a specific question. If you are able to answer that question, then come. So because of that, I'm trying to give the specific answer to these questions. As far as this is concerned, the specific question is whether to use in neonatal conversions. Already is being used in pediatrics. The problem is in newborns because there are no sufficient evidence. Now, if at all we have to use, when to use, which type of seizures, how much to use, how long to use. This is the specific question everybody is facing right now because of the new drug. Now, before going to that, let us go for this Indian version of evidence-based medicine. What we practice is the Western version. The Indian version is nothing but way back, many centuries back, there was a debate between Shankaracharya and Mandal Mishra. This debate is not of importance. What is important for this one is what are the rules of the game? Rules of the game were very clear. In Sanskrit, there are three rules of the game. First rule was Pratyaksha Darshanam. Have you seen that? Or you are just talking from something which are very internet. Have you seen that? Pratyaksha Darshanam. Eyewitness. Second thing is Anumana Pramana. Is it logically explainable, possible? And third is Aptavachanam. Somebody authority in that particular subject, some organization, some person, or group of person, committee has recommended anything. Out of these three, if all three are there, then we can accept it as truth. Otherwise, it's a half-truth. And unfortunately, as far as Levetiracetam is concerned, there is no authority or no guideline about use of deodorants. So we are left with only two, that's logic and eyewitness. As far as eyewitness is concerned, let us go for these are studies. These are the studies. We will go in details of this study. When we come across study, first of all find out the numbers 280, 23. One is huge, one is very small. After that, very small, 1.1 each. So out of that, go for results. In majority of these studies, the results are mixed. Some of them are worked, some of them are not. Because they are used it for all seizures. And there is a lot of variety in causes of seizures also. Some causes have not responded, especially single bar formation, gross hemorrhage, they have not responded to this drug. More interesting is this single one. This is our stereotype baby. All over India, we come across this baby. Seizures are uncontrolled at 10 days of life with phenetoid clozapine, diagnosis of malignant migrating partial seizures and all those things. Levetiracetam was started at 10 mg per kg, increased to 30, and after that, seizures activity reduced from 66 a day to 1 per day. This is a very, very bad seizure disorder. So, if the disease is mild, no drug will work. If the disease is severe, no drug will work. So, real test of any drug is whether it's going to work, a real difficult scenario. So, let us follow that particular thing. So, actually, I'm sorry, I'm not able to play videos. These are the videos of babies which actually we are treated. In our unit, we are treated with Levetiracetam. We have gone from 20 mg per kg, sometimes to 60 mg per kg per day. So, we'll take it now. Let us go for logic. Now, because of logic, what are the things we discussed today? Normal neural brain. What happens in convergence actually? Drug action, how it acts, and conclusions. This is normal neural brain. If you go for this one, you will find at the center is thalamus. This particular thalamus part is the gate of all sensations. All sensations pass through this gate. And from this gate, this is projected from a cortical river ventricle circuits to and fro. You commonly must have heard that really difficult seizures, there are stimulus sensitive. Just we talk, just we touch, just we handle the baby, they keep on fitting. This particular thing is proof of anocortical to and fro circuits. Then there is RAS, reticular activating system. It is heavily dependent on sensory state of wakefulness. So what happens in convergence actually is a balance. Some of the drugs, some of the substances, they excite the brain. Some of the substances, they depress the brain. So imbalance between these two substances actually is the reason for majority of convergence. This will tell about epileptogenic potential. Epileptogenic potential is different than epilepsy and different than convergence. This potential means there is a background, that is a foundation on which any insert happens or just a cyclist insert happens, maybe goes for convergence. So what is this one? Glutamate. Glutamate is something which excites the brain. GABA is something which depresses the brain. If this is heavy, if glutamate excess is there, then this baby will have difficult to control convergence. And here is the drug comes. So what happens here is, this is the complete complex, very simple. This is the astrocyte. These are the neuronal ends. This is the astrocyte. These are the neuronal ends. Now this astrocyte gives rise to one important part, substance, glutamine. This glutamine can go this side, can go this side. They are going to have two diametrically opposite faces. This glutamine ultimately can go to glutamate, or glutamine can become GABA. Glutamate, as you know, excites, GABA depresses. So this is the foundation of almost majority of anticonvulsants used in neurons. GABA agonists, glutamate blockers, and all those things. How this drug acts? Levetiracetam. How this drug acts is this glutamate, which is synthesized in presynaptic area, is not allowed to burst open into this cleft in excess than required. Very important everyone, that this glutamate is not allowed to go into this area in excess than is required. That means it should not block the normal transmission. If it blocks normal transmission, normal development of brain won't happen. It will be harmful. So, the glutamate transmission is allowed, but the excess is not allowed. How it happens? Before that, we'll go for this types of neural seizures. This type of, so many classifications are there, but usually we come across four things. One is subtle neurosis. Second is multifocal, generalized tonic and mild. What happens actually here? Here if you see, this is the cortical neuron. This is very too simplistic. Actually, it's not as simple as that. This is something which is cortical neuron. This is subcortical neuron. This cortical neuron is exerting negative influence on subcortical neuron. It's telling the subcortical neuron to cool down, calm down, clamp down. So this particular negativity is there. Suppose this doesn't work, then uninhibited action of this lower cortical neuron leads to repetitive stereotype movements which are otherwise normal. We call it as subtle neurosis. Second type is multifocal. When this positive phenomena are going on at multiple places, we can get multiple focal. This is the negative phenomena in subtle. Multifocal is positive phenomena. Generalized tonic and mild tonic usually are subcortical. In case of generalized tonic, it is a very poor prognosis, rare prognosis, in the subpretum especially. That is, this RNS is activated. Now, this is thalamus. This thalamus will have sensations, and this thalamus will produce the cortex, and there will be two and three. This is the basis of different locations of different types of seizures. Our interest here is myoclonic. In myoclonic, what happens is that in this subcortical neuron is discharging too much of glutamate into this synaptic cleft. And here is the role of this drug. Now, what are the mechanisms of action? Very difficult to understand all these words and let us make it kind of simple. This is just a group of people. They are trying to communicate with each other. For example, this person is telling this person, aage badho, and they are moving like a wave. But one person has become mentally deranged. He suddenly shouts, aage badho, too much. And what happens? Chaos. This signal to noise. At certain stage, there is too much of noise, disproportionately high noise, and that leads to chaos. And this orderly movement will be disrupted. Now, this signal to noise ratio is something which depends upon cytosolic calcium. This cytosolic calcium level is very important for signal to noise ratio. If this cytosolic calcium level is high, signal to noise ratio will be more, and this drug tries to dampen it. Second is this particular SV2A agonist. What is that? So this SV2A agonist is something which this is synaptic vesicles are there. These synaptic vesicles they are containing glutamate, and this glutamate goes into cleft. This synaptotagmin is a calcium sensor, and this calcium sensor after that causes exocytosis. And this SV2A protein tries to regulate action of synaptotagmin. And this particular drug, Levetiracetam, is an analog or ligand which acts like potentiates the action of SV2A. So in short, less glutamate is liberated into cleft, and signal to noise ratio is reduced. Now what happens? Now let us come to conclusion. That conclusion will not be perfect. It is based not on any guideline or something, but can be used in neonates. Because in neonates, glutamate excess as compared to GABA is already known. Second is, do not use in subtle and generalized tonic seizures. Why? Because in subtle seizure, it is not a positive phenomenon, it's a negative phenomenon. Second is, generalized tonic seizures, RNS is involved. For example, it's called reticular reflex myoclonus. In this situation, there is already found in experimental studies, if you induce seizures because of electrical shock or chemically induced seizures, this drug does not work. But if you put pilocarpine into a regular mouse, then this drug works. So, using myoclonic seizures, especially stimulus-sensitive thalamocortical neurons. This looks very complicated, but all of us have seen that once you handle the baby keeps on fitting. Clonazepam doesn't work, Phenobarbital doesn't work, neonatal doesn't work. In this particular situation, this particular thing can be quite useful. Now, guidelines are clear. No, it does not exist. Still, this drug is not at all what we can say coming mainstream. Still, mainstream is phenobarbital and levetiracetam. Now, practical consideration. When to use, which type of seizures, how much to use, how not to use. Now, this is a trial, study done. What happened? There was status epilepticus. After status epilepticus, it was controlled by diazepam, and after 4 hours gap, this drug was given. And they tried to find out whether this drug is able to prevent development of epilepsy, gynecogenesis. No, answer was no. Then this particular study was interpreted by 2 groups of people by 2 different ways. One group said it is useless, one group said it was given late. So if you go either way, if you want to prevent epilepsy in future, use it early. Why it's important is sometimes new drug we use it 3rd line, 4th line, 5th line, last stage. But in some specific situations, if we use this drug early, it may reduce the chances of epilepsy. Now let's compare with the conventional therapy. Conventional therapy is phenobarbital, as all of us know. Now, phenobarbital respiratory depression action is present. When we are giving phenobarbital, especially in an area, remote area, we are very much afraid about respiratory depression. We are actually keenly watching the abdominal movement. This respiratory depression is not present in this particular. Myocardial depression. This is very dangerous on those babies who are already on ventilator. Since babies are ventilator, sometimes we become careless and we end up giving more phenobarbital, which can lead to shock and arrest, bradycardia. This also is not present in this drug. Metabolic demand decrease by phenobarbital, it is questionable. Multifocal chronic seizures, which is very useful in phenobarbital, but this particular thing is unknown. Because don't prepare a novel drug, new drug, when actually some old drug is actually working quite well in the situation. For example, the multifocal chronic seizures, phenobarbital is working quite well. It is quite safe. So this actually is unknown. Myoclonic seizure is something where phenobarbital does not work well. Less useful. It is more useful. This is important drug interactions. Why? Because phenobarbital is alcohol, you know that it induces hepatic microsomal system. This particular cytochrome action is not present in levetiracetam. So add-on drug, add-on therapy. Suppose something is going on, we are not happy with control. Add-on levetiracetam can be useful. Because it won't interfere with other drug laws. Now, let us compare with long-term thing. Valproate, another drug. Valproate, as we know, liver dysfunction can happen, which does not usually happen with this particular. Second thing is ammonia. As we said in the previous slide, during formation of glutamate and fate of glutamate, ammonia is involved. This ammonia handling is already important, and if ammonia is already poor, ammonia handling is poor, in this situation, especially metabolic IM cases we have encountered, this valproate can actually worsen ammonia. So in instances where there is increased levels of ammonia, it is safe. Pharmaco resistance is the concept. Just like drug resistance, there is pharmaco resistance, antibiotic resistance. Here, this is seen, this is not seen with ongoing use. So neonatal dosing. It is not known actually. How much dose is actually given is not known. But recommendation is 40 mg per kg per day. Some units start with 20 mg per kg also. There is a risk of overdose. 1 cc contains 100 mg. Sometimes we tell them about oral preparation 0.1, 0.2. Sometimes they end up giving 1 and 2 ml also. 10 times high. But fortunately till this time, fatal accident overdose has not been encountered. So, can use higher doses in exceptional circumstances. The therapeutic window and the safety window, here the safety margin is quite high in this drug. Now, how long will you give? Don't get too excited with some new drug, because old drugs actually around here for a long time. We know the side effects, cognition with cardinal. But this particular drug, we know that there can be a problem in future. Don't use this drug right away, because ultimately there has been studies with radiolabeled drug. They found out that they zoom in into one particular area, that is hippocampus dentate gyrus. And this gyrus is important for memory. This gyrus is important for, there is some convergence also. So episodic memory, and most important part is novel environment exploration. That particular child should be able to explore novel environment. This can impair in future. So be careful for long-term use. So dentate gyrus is a part of hippocampus, involved in episodic memory, and levetiracetam prolonged use has potential side effects, including hyperactivity, psychosis, tremors. So carrier message is quite brief. Routinely don't use, because phenobarbital has worked quite well till this time. There are certain instances where it doesn't work. Anticipate that and then use it. Can be used in stimulus-sensitive microtic convergence. Higher doses are tolerated better. In our unit, we have sometimes gone up to 80 mg per kg also per day. It is 40 mg per kg per dose daily. But still we will come across any side effect, especially because of multiple convergence acidic molecule causes more of depression. That is preventive. Acidosis comes down, baby comes out automatically. Stop as soon as primary etiology is better. Thanks, sir. Thank you.
Thank you, Dr. Yadav. May I request all the speakers to please come on the task. We can allow 3-4 questions from the audience.